Sarcomas were one of the first tumour types for which multidisciplinary clinics were set up. There are more than 100 different types of sarcoma, so accurate diagnosis is essential. All treatment and diagnostic disciplines need to meet to decide on the appropriate treatment for an individual patient. This special edition of the Journal of Cancer Metastasis and Treatment exemplifies the multidisciplinary nature of sarcoma care, with articles on translational research, basic biology, pathology, surgery, and survivorship. Treatment for many cancers is now focused on molecularly targeted therapy and immunotherapy, but as yet that's not the case for the majority of sarcomas. Yes, in the year 2000, with imatinib in gastrointestinal stromal tumour, we began to learn about the success of targeted therapy in that particular disease, for which we now have 5 registered agents. But it's an outlier. It's driven by activating mutations. For other sarcoma subtypes, development has been slower. Many have complex karyotypes and a lack of easily identifiable drivers, and many are extremely rare. There is a sizable subset which are driven by gene fusions, but even when a gene fusion is known, that doesn't necessarily lead directly to a targeted therapy. For example, synovial sarcoma. The X18 chromosomal translocation was first diagnosed 33 years ago, but the genes involved only 25 years ago, SYT, SSX1 and 2, and the mechanism of action whereby the fusion protein disrupts the SW1 SNF chromatin modelling complex only recently being unravelled. For example, the work of Caddock and Crabtree in 2013. We are increasingly seeing sarcomas being classified according to their molecular characteristics, something that happened years ago in haematology. One example is the small round blue cell tumour associated with the KIT-6-DUX fusion, now known to be a discrete entity. It's a poor prognosis, aggressive disease, responding poorly to chemotherapy, quite unlike Ewing sarcoma, but it used to just be lumped together as one of the Ewing family tumours, a term we no longer use. There are some good examples of treatment according to molecular characteristics. We have ALK inhibitors like crizotinib in inflammatory myofibroblastic tumour, rapamycins in PEComa, imatinib also for DFSP and tenosynovial giant cell tumour, inhibitors of the histone methyltransferase ECH2 in epithelioid sarcoma, for which tazemetostat is now approved. The paper in this issue from Karolak and colleagues discusses the role of ECH2 in sarcoma and how inhibiting this key enzymatic component of the PRC2 chromatin modelling complex may be useful in sarcomas, including those in which SMARCB1, or otherwise known as INI1 loss from the SW1 SNF complex, causes reciprocal upregulation of PRC2, hence EZH2. In another paper, Abe and colleagues discuss the possible role for inhibitors of glycogen synthase kinase 3 beta. It's a key enzyme which has an important role in the body, but also may play a role in tumorigenesis when it's overexpressed, associated with upregulation of NF-kappa B, and hence cancer cell survival. It may be important in a wide variety of sarcomas, including osteosarcoma. There are inhibitors available, but as yet no sarcoma studies. ROR2 is identified in a paper by Tran and colleagues as involved in the development of pulmonary metastases in a model of osteosarcoma, where it contributes to anchorage-independent cell survival. It's currently unclear whether this pathway is important in established metastases or exactly how an ROR2 inhibitor would be studied in the clinic, but we must surely be able to learn important lessons about how metastases develop in this difficult disease. The paper by Pacheco and Righi from the Rizzoli Institute deals in detail with the pathology and clinical behaviour of tumours of the bone surface, both benign and malignant, some of which are extremely rare. It's a definitive paper and clearly of particular interest to orthopaedic oncologists, musculoskeletal radiologists, and of course pathologists. The paper by Pinamani and Dameron talks us through the reconstructive procedures for the proximal humerus in the case of cancer involving this site. It's a difficult area since stability of the shoulder joint crucially depends on surrounding tendons and muscles. There have been no definitive trials comparing different approaches, so the relative advantages and disadvantages of prosthetic, allograft, composite, prosthetic allograft procedures are dealt with in detail in this paper. And finally, we have a paper on survivorship. As more and more patients with cancer are cured, the long-term problems caused by the treatment become increasingly important. The paper by Baker and colleagues deals with the long-term issues caused by sarcoma therapy, including chemotherapy with anthracyclines, in particular coronary artery disease. Many surviving patients suffer from mobility issues and psychological problems. But obesity, type 2 diabetes, hyperlipidemia, hypertension are all common and exacerbate the coronary artery disease that is seen following prior anthracycline therapy. Managing those comorbidities properly can mitigate the damage, improve survival, and improve quality of life. The key question is who should be responsible for the long-term follow-up of sarcoma patients, something that is going to be different in each health jurisdiction. So in conclusion, we're encouraged by this collection of papers giving sarcoma a real focus. We should look at the whole patient and fully appreciate the multidisciplinary nature of sarcoma care. Thank you.